Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers, producer of Public Health on Call. Americans take a lot of prescription drugs, which are often vital to survival, but can also cause harmful side effects that end up being treated with more medication. Today, Stephanie Desmond talks to Johns Hopkins geriatricians Dr. Cynthia Boyd and Dr. Ariel Green about how to regularly reassess whether you're taking the right medications and how to prevent dangerous drug interactions. Let's listen.
Cynthia Boyd and Ariel Green, thanks so much for joining me.
Thank you for having us. Glad to be here.
So today I want to talk about something called polypharmacy, which we will define momentarily. But basically what it comes down to is my understanding is that 1 in 5 adults ages 40 to 79 is taking 5 or more prescription drugs at a time. And so I guess my question for you, Cynthia, is why? How does this happen?
Great question. So I think many times it's an unintended result of what we would absolutely say is good healthcare, right? Like we have many effective treatments that are both preventive, meaning that they prevent something bad happening in the future, or that are treating chronic conditions people have. By chronic conditions, I mean something that lasts for a period of time, not a short-term illness. And many times medications kind of accumulate over time as a result of trying to do the right thing by our patients. But it's really the use of multiple medications. And sometimes the use of multiple medications is absolutely what the person should be doing. But sometimes and over time, the number of medicines tends to accumulate, and we don't necessarily always do a great job of reevaluating which ones are still right for the person, has the benefit and harm balance of each individual medication changed over time. Those are the things that come to mind.
Ariel, tell me a little bit about, there can be lots of interactions if there's lots of drugs. What do you see?
Yeah, so drug-drug interactions are definitely a common problem. We also see drug-disease interactions where people are taking a medication for one problem and it causes or exacerbates another problem. I would say we see that a lot, probably even more often than flagrant drug interactions, because we do have some systems in place, I think, to prevent the obvious drug interactions. So, we have like alerts that pop up when you order something that has an obvious drug interaction. That being said, I think there are probably more subtle drug interactions that are going on that we're not even always aware of. And then there are the drug disease interactions that I mentioned. And then those lead to drug cascades where a drug causes a side effect, and then we prescribe another medication to treat the side effect of the first drug, often without realizing that that's a side effect. That's sort of another interaction in a way.
And we see things, memory decline and falls and low blood sugar. I mean, people end up in the hospital because of this. How do you guys address this? And how do we get better at doing this?
I think there's a couple of ways of thinking about this, right? One is thinking carefully about each new medicine that we add, and is it the right thing for that person? I think one of the things that we try to do, Ariel and I are both geriatricians that do primary care for older adults here in Baltimore, is to really make sure we know what are the things people are taking. So starting with, what's already on the person's list, really understanding how they are taking it. Are there problems with it? Are there side effects? Are there interactions? Is it so complicated that people are struggling to get all the doses in? And just really sort of understanding where the person is to begin with. But then I think starting from that framework, one piece is thinking about okay, if we're going to add something new or we're thinking about it, kind of how do we think about it in context of not only the other medicines people are taking, but also, like Ariel said, the other conditions that they have, and just being really thoughtful, trying to make sure that the things we add are right. A second piece of it is often referred to as deprescribing, which is, I think, not necessarily the easiest term for everyone to wrap their head around, but it's really the thoughtful decreasing of doses or stopping of medicines or tapering them off in some cases, when they are no longer what's best or right for the person. And it's definitely something that we think about almost every time we're seeing people. Are each of these things still needed? Are they achieving a goal that matters to the person in front of us? Has something changed that actually now this medicine is more harmful than helpful? And then thinking with the patient and often their family, how we might go about tapering the medicine if it's a medicine that needs to be stopped gradually, and some are, or stopping it, and what's going to be our plan for reevaluating, how that change has gone.
Ariel, I was thinking about how even for younger people, certain medications are really difficult to get off of. I know that I had an experience getting off an antidepressant once. It was extremely challenging, and it ended up taking months to taper off of one and start another one. What do you do when you've got one of those kind of medications that are just really hard to stop?
Yeah, I think a lot of people have had experiences like that, which is why it's so challenging. So I think, one really important aspect of deprescribing, as Cynthia mentioned, is having a thoughtful, planned process that's supervised and really supported by a healthcare professional. So that could be a primary care clinician, it could be a pharmacist. Many clinics now, including at Hopkins, have a pharmacist who works as part of the clinic in close collaboration with the primary care clinicians. And so I think that can be really helpful, having some plan in place, taper the medicine by this amount, maybe guided by the pharmacist. Call us or send us a MyChart message in 2 weeks, let us know how it's going, and then have a plan in place for what you'll do if symptoms return, which doesn't always mean going back on the medicine. It may just mean continuing the taper, but going more slowly, pausing the taper for a bit. It's also really important to add in non-pharmacologic treatments. So I think we often forget about those, or they're more challenging to implement. But studies have shown they, for things like depression and pain, they can be just as helpful, if not more helpful often than medications.
And you're talking about supplements?
No, so things like physical therapy for pain or talk therapy for depression and anxiety, acupuncture, just physical activity for older adults or people with cognitive impairment, sometimes just having more structured social and cognitive and physical activity. So things that people can get, for example, at a senior center can help with pain, can help with depression. So I think making sure that we're always incorporating those non-pharmacologic approaches and also giving people the support they need to actually implement them.
Cynthia, I'm thinking, clearly I have supplements on the brain. I imagine that people also are taking supplements that maybe you don't know about as their doctor, and that could be causing some of this harm.
So I'm glad you brought that up. Yes, definitely. I think when we're trying to see what medicines people are taking, we really want to know what the supplements or over-the-counter medications are that people are taking. I really encourage people to bring their medicines with them, particularly for a new patient visit or an annual checkup, just because it is amazing to me sometimes how often the list that we have in the EHR does not actually match what people are taking. And I think supplements are one of those pieces. And certainly some supplements there is really good evidence for specific conditions or specific types of preventions. But I think sometimes when people are really feeling overwhelmed by the number of pills that they're taking, that it's too many to take at once, or, that their whole day is sort of taking lots of different medicines. Definitely sometimes supplements are things that can be stopped. The categories of things we think about stopping might be something that's high risk or become high risk. Maybe it used to be good, where there's not a lot of benefit that's coming from it, that we know how well it works or what it is that it's trying to improve, or that it's just really not needed, or when it's not aligned with what the person or their care partners that are there helping them, like what their goals are. And so I think sometimes supplements are falling into one or more of those categories. But I think the main thing is trying to have open lines of communication with your provider about what they are, because sometimes they actually do cause interactions, or maybe making another condition that you have worse. And more is not always better as well.
Now, we mentioned these drug interactions, and then we mentioned the side effects that happen that we are not prepared for. Is there a way we could overhaul maybe the electronic medical records in a way to make this easier?
I mean, I think there's two parts of that. I think the first part, even before we get to overhauling the EMR, I think is just for all of us, both patients and family, but also clinicians, to just have in our mind that side effects are not always the obvious things that we think about, but a lot of times, especially in geriatrics clinic, we see people who have things that are symptoms that are just attributed to aging or geriatric conditions. So things like fatigue or dizziness or falls or poor appetite that could actually be adverse effects of medicine. So I think just being aware of that so that we both ask about things that, we don't just attribute things to aging, and also that we think medicines first and think side effects first. So kind of have that in the brain, that just as medicines are really helpful for so many things, there's always the potential for side effects. So for example, someone who has dry mouth or nausea or constipation because they're taking 10 different pills every day, it would make sense that they might have a poor appetite as a result of that. Or someone who's falling or sleepy, that can often be helped with stopping medicines. So I think just being aware of it so that we ask about it, and then maybe there's ways to have the EMR prompt patients and care partners to answer those questions, to identify those sorts of side effects before a visit with a questionnaire, maybe that they could fill out that would go to their clinician, or prompt clinicians to remember to ask about those sorts of side effects at visits. There's probably ways to use natural language processing to find those symptoms in a chart. So I think there's a lot of different ways that we could probably be better about that. I think one last thing I'll say is that we do know already that even older adults who have experienced problems that could be related to medication side effects, so things like going to an ER for falls, that we don't currently do a very good job of, even after someone has had a serious event like an ER visit or a hospitalization, stopping medicines that could be related to that, or even talking about the fact that those medicines could be related. So I think we could definitely do a better job of having the EMR alert us to that and take action.
Cynthia, I'm going to give you the last word.
I was just going to add that Ariel had so many beautiful examples. I think that one of the things we really want to do is try to normalize patients asking questions about their medicines. Like, do I still need all these medicines? Could you take a look at my medicine list? I'm not sure what these 2 or 3 or 4. Could you walk me through this? And I think that EHR can also help us deliver materials that might empower patients or families to basically be thinking of, hey, is it time to take a look at my medicines and just make sure that they're all still needed and I'm at the right doses? And so I think as more and more people are getting on patient portals, I think there's an opportunity to be also information sharing, that, when patients are at a visit, that they're sort of primed or ready to be having those conversations with providers.
Cynthia Boyd, Ariel Green, thank you both so much for joining me.
Thank you so much.
Yes, thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.